and is in the third year of her PhD, and will present on the project she's doing and the methodology and interim findings. And her topic is exploring the potential of task sharing to improve mental health support for women who are single parents on low incomes in Edinburgh. And you'll see on the advert for today's seminar there's a background to Natalie's project, and she's going to give us an overview and talk about her approach to the methodology and the findings that have emerged so far. So over to you, Natalie. I think Natalie's going to speak for maybe 35 minutes or so, and then we'll have time for discussion.
Great, thanks, Neil. I'll just share my slides. Hopefully you can all see those okay. Great, okay. So yes, as Neil said, I'm going to be talking today about my PhD research. The project is part funded by NHS Lothian and also involves the City University in New York, and is supervised by Neil and Cara. And I wanted to start today by talking about one of the women involved in the project. So Caitlin is in her late 20s, and she lives in Edinburgh. She has a young son who has additional support needs. And when she became a single parent, she struggled to understand, her friends struggled to understand why she was never available. And this led to her losing a lot of friendships, and she became increasingly isolated. She did have a part-time job, which she lost during the pandemic. And she ended up becoming quite depressed. She ended up finding some community organisations specifically for single parent families, which she's joined, but she was still feeling very low. But she put off going to the doctors because she was worried about being reported to social services and what the implications would be of saying that she was struggling. When she finally plucked up the courage to go to the doctors, she got a 10-minute appointment, which she felt was quite rushed, and she felt under pressure to take medication because of the long waiting list for counselling. But she persevered on the waiting list, and she was eventually given 20-minute sessions of cognitive behavioural therapy. And she reflects on this here. So I would go in, I'd say a few words, he'd explain some stuff, and then he'd be like, oh, sorry, I need to finish up. And then I'm waiting a month or two till the next one. So then I forgot what he said at the previous one. I've not been a lot because he just kept saying that he didn't have a lot of appointments and it was really short appointments. So I've got so much paperwork to look through at home. I try and do it when my son went to bed, but I'd struggle to take it in. So unfortunately, Caitlin's experience is not unique. In Scotland, of 218 people recently surveyed, 48% were not referred for psychological therapy and 49% were prescribed medication without psychological therapy. And this is particularly concerning when we consider the meta-analysis of studies that has shown psychotherapies outperform other methods in the treatment of depression. This has prompted Vikram Patel, who's a lead figure in the field of global mental health, to argue that task sharing of psychosocial interventions is the most important priority for mental health policy and practice. I should also mention that I'm interested in common mental health disorders, which include depression, but also anxiety. So what exactly is task sharing? The official definition provided by the WHO is the rational redistribution of tasks among health workforce teams, where specific tasks are moved where appropriate from highly qualified health workers to health workers with shorter training and fewer qualifications. There are some really innovative examples. A lot of this work's come from lower middle income countries where there is little or no resource. And this project here is one quite famous example now, the Friendship Bench, where well-respected community elders have been trained to deliver talk therapies on wooden benches, getting out of clinical settings as part of a step care supervisory structure, so supported by a team of clinical psychologists. And they also receive kind of peer supervision as well. Importantly, they're involved in shaping the say, intervention, the approach, and changing the format and the language to best meet the needs of the people that they're supporting. When I was doing my literature review, I became really interested in these approaches. The evidence base is really impressive in terms of their effectiveness, and they've started to become popular in more widely in more countries. In spite of this, task sharing of this nature, so involving lay health workers, has been quite slow to develop in higher income countries. There are some approaches emerging though, with a particular emphasis on adolescents, BME populations, so where there is an obvious sort of cultural difference, and veterans. And I would say there's a gap in the literature looking at how to involve people with lived experience in the adaptation of approaches. So a lot with kind of how to deliver, less about how to adapt the approaches, but also how it feels to be involved in those processes and the feasibility of peer-led counselling. How would people feel about receiving counselling from what might be described as a non-professional? But I'll come back to this shortly. The reason why these kind of approaches are popular is because of the simplification of talk therapies. So in some cases, it might be cognitive behavioural therapy, but I'm particularly interested in interpersonal counselling, which is a simplified version of interpersonal psychotherapy. So the idea with this is that it can be easily taught to a wider range of professionals or people with no background in mental health, as long as the personnel is carefully chosen and the process is systematically described. So you see a lot of kind of manualized guides, a lot of resources and tools that people can use to support them through the process. And in IPC is an emphasis on here and now issues. It's not digging up things from the past. It's very much about dealing with issues with relationships, roles, support networks, is quite relevant to stigma. And there's some evidence to show that it's effective for single mothers on low incomes. Just to mention also that one of the funding partners at NHS Lothian was involved in work developing IPC in Edinburgh, so that presented somewhat of an opportunity as well. I want to refer as well to Veterans First Point, which is a project I only found out about once I started my fieldwork, that actually is piloting a project training the veteran peer support workers already recruited to deliver IPC through a step care structure, as with the Friendship Bench, supported by a team of clinical psychologists. That's underway at the moment, and in this case, peer support workers are paid on Band 3. And I'll be referring to them. I've interviewed peer support workers and others involved in this project as part of the fieldwork, so I'm going to be referring to V1P later on. So taking it back to the focus of this study and why I wanted to focus on single parents in Scotland, I've already talked about the experiences of Caitlin, but single parents experience brief and repeated periods of poor mental health, well above those of even couple households. They're twice as likely to experience poverty. There are high levels of both kind of perceived and evident stigma related to anti-welfare rhetoric. There are multiple practical and perceptual barriers that prevent people from help seeking. And there's some recent evidence that actually Neil has been involved in gathering, demonstrating how single parents have been disproportionately impacted by the pandemic. Excuse me. So I had some research questions going into the project, and the first was how mental health issues are experienced by single mothers on low incomes and what their perspectives were on mental health support, how communities can influence the design of an interpersonal counselling intervention in ways that feels meaningful and supportive using internet-mediated methods. I was doing my fieldwork in and out of lockdown, so it all had to be online. And then what the implications are of participatory and collective approaches to mental health provision for the full range of stakeholders. Similarly, what the wider implications of research findings are when we consider the potential of task sharing in mental health care in Scotland, the UK and globally, so situating this within the wider global literature. Choosing participatory action research was an easy decision for me. I'm not a single parent, I'm not a mental health professional, so there were quite big gaps in my knowledge, and it was really important that I brought together a range of expertise. Involving marginalised populations has been shown to improve the accessibility, service quality, impact, community cohesion and leadership. I really hope that even though this is a very small scale project, it does something, and that there might be some buy-in and an opportunity to take things forward once the project had been completed. So a participatory approach supported that. But the project's underpinned by an extended epistemology. So this is acknowledging the value of bringing together a range of expertise, lived, practical and professional, to effect change. And the approach is supported by guiding principles, including accessibility, consultation, flexibility, verification, reflexivity and acknowledgement. So as I'll go on to explain, I chose to work with a smaller number of women, as I wanted to have repeat engagement and opt for depth, I guess, over breadth in that respect. But because I entered the project with research questions already, and because the funding partner also had a specific interest, I need to be transparent that this is not completely participatory. So I found this quite useful, this axes provided by Aldridge about where to kind of situate the project. And I would say that the project's probably more about participant as subject and participant as actor. And with more capacity, I would have liked to get participants a little bit more involved, perhaps in the research activities, but that was just beyond the scope of this study. So to describe quickly what I did, the infographic on the right here describes the overall process. So I began by setting up an advisory group of development workers from community organisations who also happen to have lived experience being a single parent on a low income, a strategic lead from NHS Lothian and 2 clinical psychologists. I began by conducting some scoping interviews with prospective participants in the study who commented on the plan for the group work stage later on. This was a chance for me to get to know them, understand their motivations for taking part, any concerns they had, make sure that they had everything they needed in terms of accessibility. So we did test runs on Zoom and made sure that they had as much control as possible over the research environment, turning cameras on and off, using a background, etc. But also thinking about the practical implications of participating. So the project was actually stripped back quite a bit. I was very ambitious with my plan, and having kind of recognizing that the limited time available to participants, I really sort of stripped that back to make it as easy as possible for people to engage. So following the scoping interviews, I reviewed the findings with the advisory group, and then sent the revised plan to participants just to check they were happy. And we started with the group work stage, which is described a little bit more detail to the left. I split the group into 2 smaller groups, and we had 5 weekly workshops. I sent a survey out at the end of each workshop just to see how people were finding it, and tried to respond to their comments week on week. I also kept my own research diary. This was a new approach for me. It was a steep learning curve, so it was really important for me to reflect on how I felt things were going. Just also to mention, as a result of the advisory group, it was suggested that I complete 2-day IPC training. And one of the hardest bits with this project was finding a way to explain interpersonal counselling to participants without jargon, and there was practically nothing available to do that. So I ended up creating an information video with the support of a clinical psychologist just to check everything was accurate, so that I could share that with the participants to prompt discussion. And running alongside this, I've been conducting interviews with wider stakeholders. So I've done 22, which includes development workers, counsellors, peer support workers, and clinical psychologists. And to explain a little bit more about what we did within the workshops, the first workshop was very much about mapping how people felt about mental health support, where they felt, what they felt worked well. There was some great stuff already happening, where the gaps were. And the second 2 workshops were looking more specifically at interpersonal counselling. And for this, we had the video, but I also pulled out the kind of visual aspects of this, so examples of the concepts, which I then shared on the whiteboard, and we just used post-its to reflect on how effective, what they thought about these, and how they, if they think what they think of the language, and if they think anything needs to change. And in the last workshop that was dedicated to peer support, both kind of the opportunities of peer support within an interpersonal counselling approach, but also more broadly, so we have much broader discussions about peer support. So jumping into the findings, I really started off with trying to understand how the participants felt about the term lived experience, because this was at the centre of what I was trying to do. And I started off in scoping interviews by asking them how they felt about the term single parent. And while some felt that this had a really kind of broad idea about who was included within the term single parent, which included people in couple households whose partner worked away, others were very specific that this was, it should be a narrow definition, and wanted to distinguish their experience from other single parents who they felt had more social support. So this quote captures that. It really bugs me when people use the term single parent when they're actually not, they're co-parenting and things. So there was a bit of sort of distancing happening, but what was really interesting is that at another level, there was something quite unifying about the experience of parenting on your own. And I found that this was more related to structural oppression, stigma, and isolation. So this element of feeling in some way victimized, but having suffered the stigmatic views and structural oppression. So this is one of the comments that was made about the motivations for the project. I mean, obviously money's great, but it's not one of the things that's motivating me to contribute towards this. It's more that, and she begins to cry, I think people like me need to be able to, we're not given a voice, there's just nobody listening. Policymakers at every level, decision-making don't consider us, and it's just so frustrating because we've got so much we can give and we're just constantly up against it. Constantly firefighting and trying to keep our head above the water at every single level, and it shouldn't be this hard for people. Similarly, in relation to experiences of at the job centre and welfare reform, this idea of being constantly monitored, scrutinised, having to prove yourself, and that chipping away at your self-confidence and self-esteem. The job centre they really don't understand the situation. They just say, oh, you need to look for a job, you need to work a minimum of 16 hours because you're doing the courses. And I asked her last time, where? Can you show me which day, which one? I see you have all the details of what I'm doing and how many hours. And they say, oh, we'll cut the benefits for you because if you don't find the job, and it's the new law coming in. And in relation to stigma, I never sort of say the term in reference to single parent to a lot of people. I just keep it quiet. If I think they're maybe not a lone parent, I don't know why, I probably do still feel that there could be a stigma with the single mums or single parent thing. I don't know why, I've just always thought there might be a stigma. So these reflections were made whilst speaking about single parents as a much broader group. And it was agreed that we would use the term single parent because there was no better alternative. So how are mental health issues experienced by single mothers on low incomes? These are some of the, at the top here, the emotions that were mapped out when we were doing the exercises. But one of the things that came up was the tendency to try and just cope. So this could be because of intergenerational stigma, so parents suggesting that this is just what it's like to be a mum, or particularly if they've been a single parent, well, this is the reality of being a single parent. Maybe also trying to prove something if the families disagreed with the divorce process, fear of social services, employers not understanding, so not wanting to say anything to employers, and particularly if they've had to ask for more time off because of childcare issues, and distrust in professionals. So as Magda describes, I was struggling for a long time before I decided to call another doctor and ask for help. I was trying to be strong because of my daughter. She's just a baby. For me, it's the only person I have in this country. So there's a real sense of threat about child custody. The feeling of being overwhelmed was raised frequently, and the need for headspace, childcare, and social support. Similarly, the pressure to take medication and the long waiting list for counselling when you finally sought help. So in terms of the perspectives for mental health care, there was a need for more accessible counselling, so counselling that could be accessed more quickly, but also that was explained properly, so the concerns that things like CBT could sometimes be a bit confusing and not always properly explained. There was a lot of amazing informal peer support happening through community organisations, so walking groups, family days and classes. And there's a lot of emotional work being done by kind of overworked development workers, bending the funding rules so that they could invite someone to a group just to improve the dynamic of that group, or introducing families to each other and doing a lot around cultural integration, so cooking classes and things like that. One of the things that was important about this was speaking freely, so not necessarily speaking about issues, but being able to say if they've had a really bad week, without being worried about people reading into that or it being escalated. But there was a real lack of structured peer support roles. The wider stakeholders all kind of saw the value of that, but because of funding and capacity, there was hardly any structured peer support. And I've used this example here of a WhatsApp group that was set up to demonstrate the implications of that. So one of the development workers had told me that they started a WhatsApp group because his hours had been reduced so that they could communicate and talk when the services weren't running, because that's what they tried to do, facilitate the groups. We don't supervise, but we're trying to empower the families, and we've seen that take off big time. But I'd already spoken to the women about, they brought this up about the WhatsApp group previously, which they'd all left, because one of the women explained, if you're going through your own stuff and other people are constantly putting problems and stuff, sometimes you're just taking on their problems. It just became too much, and the messages were coming all the time. So I think without this kind of allocated person to be in that support role, these more informal, relaxed groups are being used inappropriately. And in terms of how communities can influence the design of an interpersonal intervention, developing the IPC video using projective techniques and discussion meant that the participants could meaningfully engage with the tools and concepts. However, this was hard to do. And one of the sessions I ran in the evening, I really didn't want to go over an hour. So there was a limited capacity for that, but I have positive feedback. So comments like, we never get asked about this sort of stuff. It's not like anything I've done before. Using the internet was safer at the time, more flexible. To some extent, it gave participants a bit more control. However, I also struggled to get creative, especially since I couldn't give any of the participants stuff to do outside of the sessions because they didn't have the time. So that was also a slight limitation, but we did the best that we could with the resources that we had available during the sessions. And more broadly speaking, with the methodological reflections, what I actually found was that process of discussing IPC and using the projective techniques allowed me to get a much richer understanding of how participants conceptualized mental health and how they felt about counselling in a way I don't think I would have got with just conventional interviewing. And looking at existing projects and different concepts helped to prompt discussion. So I've sensed that they weren't really used to being asked, they were very used to being asked what the issues are or what sort of things that they liked, but in terms of kind of thinking how things could be different, that was much more challenging. And the reference to when I showed them existing projects like the Friendship Bench and others, that helped to kind of them to pull things that they liked and didn't like. And so this comment, one thing I noticed, and it's probably got nothing to do with it, but there are kids in all of the photos. This is the Friendship Bench. For me, it's less restrictive because if you needed to, then you can have people can have their kids with them and they can still access the support. Like I said before, sometimes you go to an appointment or you can't go to an appointment because you don't have someone to look after your kids. So it helped us to kind of think about how counselling could be delivered differently, maybe go into a community garden and allowing your kids to be playing at the time. And some of the one thing to mention is that peer support workers in Veterans First Point, the organisation I've mentioned before, were already kind of shaping interpersonal counselling and some of the concepts and language to better meet the needs of those they were supporting. But that wasn't recorded anywhere, and it was suggested to me by the mental health professionals that that wasn't something that was happening. Which takes me on to what opportunities there are for peers in an IPC intervention and more broadly. So participants are actually really positive about receiving counselling from a trained peer support worker, which is seen as being friendlier and non-judgmental. and there were opportunities, I would argue, for peer-led counselling while people are on waiting lists as an alternative to professional counselling or as a follow-up. But the participants really emphasised how important it was to have options and to have clarity over the role. So for these, a lot of this is starting to blur kind of a peer and professional type of role. It's important really to kind of understand that and what's how you can expect to interact, so that you're not leaving the engagement worrying about what you said or whether you should have asked something. With this in mind, with the kind of positive reaction, this is one of the comments from the clinical psychologist, that she says, IPC was designed as an intervention to be delivered by professionals, just not mental health professionals. The modifications and differences in skills, but there's still someone's job, and that sets an expectation rather than just a granny sat on a bench. I think it's important to hold on to that distinction, and this links to the relevance of working with a script. I'd be really disappointed if I went to a peer and they were using a script, whereas with professionals, in a way, we want them to be working from the script. We'd expect that so that we know it's being done properly. This actually is not the case, not what I found when I was speaking to participants and the peer support workers. Instead, they felt that the structure was helpful, and it kind of helped to combine the best bits of peer support and professional support. I also wanted to refer to the aspect of sharing experiences, because this came up as something really significant. So at Veterans First Point, the veterans don't actually share their own experiences. They're all from the military, but they don't share their own experiences. So the quote at the top is explaining that they'll know I've served without me saying I've served, just through some of the terminology that I'll use. And I think that helps them to talk about it, because they can talk about how they want, instead of thinking about how to rephrase it so that somebody that's not been through the experience will understand. It's important because they can concentrate more on just talking. So this idea of like reaching a really quick understanding, it's not necessary for them to share their own experiences. It's actually carving out time to listen to the person who's receiving support. But they have that kind of, they have the shared language and that kind of appreciation of having a similar experience. And actually the risk of maybe sharing could be to over-identify and be reductive. And a development worker in a different organisation who also has staff with lived experience also suggested that they didn't want, they don't share because they don't want survivor victims to feel like they've got to support us and go, puts her hands on her chest, oh, that was terrible what you've been through, we don't need that. So it's this idea of kind of you putting on people that are in a difficult, already struggling. So this came through really strongly, but the suggestion from another clinical psychologist said that in reference to Veterans First Point, that they should be sharing their experiences. It's in the job description and it's what they're being paid for. So I think there is maybe a bit of an assumption here about what peer support is and what it means and what's important. Finally, I just wanted to reflect on the kind of implications. I'm not completely finished the project, so this is still developing, but just some kind of early findings and reflections. I think talking more about how to conduct participatory research to encourage more people to do it. I really love this quote from one of the clinical psychologists in NHS Lanarkshire, power approaches can seem otherworldly, spatial people in public health. I think recognising the learning that can come from lower middle income countries. So even in contexts that are very different to Scotland, it doesn't have to be the same, you know, transferring the exact model, but in terms of sparking ideas and being able to pull from different projects and just think differently. There's a real risk of exploitation, I would say. So one of the peer support workers at Veterans First Point felt really frustrated that they weren't being paid more for the work that they were doing, the counselling work that they were doing. And I think there is also a concern about the notion of giving back. So when I was talking about this with wider stakeholders, the potential of peer support, peer-led counselling, there was this talk about giving back. And I think there's a danger of peer support work being a condition of receiving support, which feeds into these kind of existing things around deserving and undeserving, which is particularly prominent for single parents. So I think just making sure that this is something that is optional and people don't feel pressured to do this. But nevertheless, I think there are really big opportunities here. A lot of the participants involved in the project were really keen on actually becoming peer support workers themselves. And there are opportunities for mutual learning between what I'm calling lay health workers, but I think just peer support workers and broad professional academic communities. A lot of this seems to be happening in a sort of disparate way. And doing this, kind of blurring these boundaries between peer and professionals, so having teams, mixed teams working together, but also maybe thinking about roles that are like professionalized peer roles would maximize the qualities of both and potentially improve mental health support. So I will finish up there. I have a list of references that I can share after the session today if anyone's interested in those. But yeah, I'm really interested to know what you think about it and whether you have any questions.
Thanks very much, Natalie. That was a brilliant presentation. So much in there in terms of the concept of task sharing, which should be good to explore, I think, with colleagues who might have experience of this, and also, yeah, a very clear overview of your study methods, findings, and the implications of your study for, yeah, research policy and practice. So I think there's so much there. Well done. And it's been great. You know, I think Karen and I have really enjoyed seeing the project develop over the last 3 years. So it's great to see such wonderful outcomes.